Okay, so now we're back and we're going to talk about the distribution. And there is a concept known as the volume of distribution, or the VD. This can get a little convoluted, so let's talk about this real quick. First of all, is everyone back before I start? Looks like it. Cool. All right. So let's talk a little bit about the VD, the volume of distribution, or what we call the apparent volume of distribution. The volume of distribution is a made-up concept. It is completely make-believe. It's not real at all. There's absolutely no reality to this number whatsoever. But the number gives us some information about the properties of how that drug is distributed. So let me just write up here on the board for you guys what the VD actually is. You're not going to have to memorize it for anything. Okay? I'll give you the volume distribution if I'm talking about a drug. I'll give it to you. I'll tell you exactly what it is. You just have to be able to look at it and go, oh, okay, this is what it's telling me about the drug. Okay, so what did I say about how we model distribution of drugs in the human body? Yeah, and when I said about, first of all, I said distribution is a chaotic, disordered kind of process, right? It's just it's so complicated we don't have a good ways of looking at how it's distributed. So what we do is we just say, well, if I give a medication, it pretty much just distributes itself evenly throughout the body, right? Like if you have a glass of water, we have a glass of water here, all right, and I have some food coloring, and I put a drop of food coloring in that water, what will happen?
It will disseminate into the water.
Right, the food coloring will diffuse out, and it'll more or less equally distribute itself throughout that glass of water. Does that kind of make sense? What we do with distribution in the human body is we say that if I give a drug, I can treat the human body like a big bag of water. And I can say the human body is a big bag of water with a big central compartment full of water. And if I give a drug, that drug will diffuse throughout the body. Does that make sense? Mm-hmm. Is everybody cool with that? So what I should do is, if I have 1 liter, let's just say I have 1 liter of water in my body is 1 liter. We know there's a lot more than that. Let's just say that. And I were to put 100 milligrams of that drug in there, and then I were to measure the concentration of that drug, okay? And I were to take a little sample of that water and measure the concentration of the drug, I should see a concentration of 100 milligrams per liter, okay? Does that make sense? There should be 100 milligrams distributed more or less evenly throughout this liter. Or if I break that liter up, I can break that liter up into decaliters, right? Or deciliters, which is 1/10 of a liter. And how many milligrams should I have per 1/10 of a liter? I should have 10 milligrams per deciliter, right? What if I take an even smaller sample of this water? What's that? Okay, I could take a centiliter, all right, and I would have how many milligrams?
1.
1 milligram? Yeah. Well, that wouldn't be centiliter, that would be 1 milligram, yeah, per centiliter. And then milliliter. Let's just break it down into a milliliter, or a cc. How many milligrams should I have per 1 milliliter? 0.1 milligrams. Is everybody okay with that? That if I measure the concentration at 0.1 milligrams per milliliter, that's the same thing as 100 milligrams per liter, right? I've just taken a tiny little sample. So what we do is we extrapolate this model to the human body. And we say, well, here's the human body here, all right? All right, so here's my, well, that's pretty terrible. Anyway. My art is not good today. Let's do like a little stick figure, I suppose. So just imagine that I have a person here, and that person is just a big bag of water. And we generally have about 30 to 40 liters of total body water. And so if I were to give 100 milligrams of that drug to that patient, and then I test that patient's water, right? I take a sample of that patient, like a sample of blood plasma, which is the water part. I should have a concentration of 100 milligrams per 40 liters, right? Does that make sense? Or what we would do is we would just take we'd take like one milliliter of this. And whatever that concentration is, I should be able to back that, go up to larger volumes until I get the total 100 milligrams. Does that make sense? So that's what our model tells us. That's what we use. Unfortunately, here's the problem. Here's the problem. Is that really how drugs are distributed in the human body?
No.
No. So let me draw the human body a little bit differently for you guys, if you will. All right. So here is the central compartment. This is our blood plasma. Is everybody okay with that? This is our blood. Now, within that compartment, we have proteins, right? Remember, we have plasma proteins, and medications can bind to proteins. Does that make sense? So let's say within that compartment, I have plasma protein compartment. And then next to the blood, I have another compartment, and we'll call this the fatty compartment. A fat or a lipid compartment. All right? Everybody cool with that? Now, do I typically sample drug concentrations in the fat? Do I typically, can I pull a bunch of plasma proteins and measure it in the plasma proteins? Not really. That'd be hard. Typically, how do I measure the concentration of a drug in the body?
Blood.
I draw a sample of blood. Okay? So when I give a medication, let's say that I give a medication that is really lipid soluble. Okay? It's a lipid soluble medication. So where is that medication going to go? Yeah, so I'm going to give 100 milligrams of a lipid soluble medication, and I'm going to give it into the blood. Some of it's going to go into the blood, right? But it's going to quickly move. More of it will move into the fatty compartment, right? So when I take a sample of this, the plasma, to check the concentration, what do I find?
Low.
I find a really, really low concentration, right? Does that make sense? Because most of it has gone into the fatty compartment. I don't see it anymore when I check the blood concentration. Does that kind of make sense? So what we do, instead of just saying that it's gone into the fatty compartment, we draw a sample and we go, it really looks like that medication got super diluted out when I gave it to the body. Now, did it get diluted out?
No.
No, it just went into another compartment and it looks like it's diluted. Does that make sense? It's not really diluted out, but it looks like it's diluted out. And so what we get is that concept of diluting is really a medication either going into a fat compartment or sometimes it attaches to plasma proteins. Okay, so the volume of distribution. All right, so the apparent, we call it the AVD, the apparent volume of distribution. The actual formula for it is the dose that you give your patient divided by the plasma concentration. You don't have to memorize this, okay? This is nothing you're going to calculate. And the units that the volume of distribution fall out in are liters per kilogram. Those are the actual units. And so this is the way it works. A medication that has a volume of distribution of approximately 30 to 40, okay? How many liters of blood, or how many liters of water does a human body have in it? 30 to 40, right? So if I have a medication that has a volume of distribution of around 30 to 40, what does that tell me?
Distributed to the whole body.
That what?
Going to the whole body.
Yeah, that is pretty well distributed in the blood. Does that make sense? That's a medication that is well distributed in the blood plasma. All right? If I have a medication that has a volume of distribution, let's say about 10, what does that tell me?
It's not very well distributed.
It's going to be going somewhere specific.
Yeah, it's going somewhere specific, and it's really kind of staying in here, huh? It's kind of staying right here in this compartment, specifically in the blood compartment, this plasma protein. So when you look at a volume of distribution of around 8 to 10, you're looking at a medication that's getting pulled up tightly into the proteins. It's a plasma protein binding. And what do you suppose if I checked my volume of distribution and it was, say, 8,000? What does that tell me? 8,000 liters per kilogram. Well, maybe. Well, this is everywhere, right? Volume distribution, or this is, yeah.
1,000 liters?
So what this means is it's like it's diluted in 8,000 liters of water per kilogram of body. So it's really, really diluted when we measure it here. Which means that, is there a whole lot of drug in the blood, or is it?
It's in the fat.
It's in the fat. Okay, most of your drug went into the fat, and when you check the level, it was really, really diluted, okay? And it's like it's dissolved in 8,000 liters of water per kilogram of body weight. Does that make sense? Whereas here, you know, you're more 30 to 40 liters per kilogram, and you guys kind of get the point there a little bit. So just a few examples. This is nothing you're going to be tested on, just to give you an idea. A medication that has high protein binding would be something called Warfarin. What is Warfarin? Coumadin. Yeah, it's an anticoagulant. And boy, doesn't that make sense that an anticoagulant you kind of want to stay in the blood, right? And it has a volume of distribution of about 8 liters per kilogram. So it has pretty good protein binding, right? It's low, it's a low number, so it has very high protein binding, which kind of makes sense, right? Because that's where warfarin works, right? It works in clotting cascade, in clotting proteins. So that's where you want it to be. A medication that is pretty evenly distributed throughout your blood would be ethanol, or drinking alcohol. Ethanol has a volume distribution of about 30 liters per kilogram. So it's dissolved pretty well. And that makes sense because ethanol is a polar molecule, right? It's polar, so it's able to dissolve in your blood quite well. This is what ethanol looks like. It's a ethane molecule, and I attach a hydroxyl, right, a hydroxyl functional group to it, and make it an alcohol, all right? And then a medication that has very high lipid binding might be something like chloroquine. Chloroquine is an anti-malaria drug, and it has a volume distribution of about 15,000 liters per kilogram. So, highly lipophilic. Okay, it virtually all of it's going into the lipid compartment. Okay, so what's the bottom line? Well, the bottom line is lipophilic drugs are going to have high volumes of distribution. Drugs that are highly protein bound are going to have lower volumes of distribution. And then drugs that dissolve real well in your blood, that are polar and dissolve real well in your blood and distribute in your blood pretty evenly, are going to have volumes of distribution around 30 to 40. Does that kind of make sense? If we're to just kind of simplify it to those 3 points. That's really what volume of distribution comes down to.
But this is just something they're going to tell you?
Yes, you're going to see this. This will be in a book, you know, you'll, yeah, this is nothing you have to, I'm not going to say, your patient has 45 liters of body water, okay, and you gave 10 milligrams of this drug to your patient, and after 2 hours you measure the plasma concentration, and it's 10 micrograms per microliter. What's the volume of distribution? Not going to go there, okay? I just want you guys to have a kind of a basic, intuitive understanding of what the volume of distribution is actually telling us. Is everybody okay there? Very large volumes of distribution mean that it appears as though the drug has really been diluted out when you gave it, okay? We know that it's not really diluted out, that it's actually in the lipid compartment, but it appears as though it's been diluted. Does that make sense? And that's because we are measuring the plasma. That's how we find out where the drug concentration is. And if the drug isn't in the plasma, you're not going to see a whole lot of it because it's in the lipid compartments. Okay, cool. Well, enough about that. Moving on to metabolism. Okay. Metabolism is a tough, tricky thing because a lot of people have a lot of misconceptions about metabolism. Like I said earlier, metabolism is technically defined as the sum of all chemical reactions in the human body. So when we talk about metabolism in pharmacology, we're focusing that more on drug metabolism, and there's a kind of a catchword, a word of the month, if you will, that means drug metabolism. I'm kind of old school. I always learn metabolism, so that's what I use, but biotransformation is making its way into the literature. So you should equate biotransformation with drug metabolism. Oh, sorry, I don't know who opened that. See all the people walking by. All right, so metabolism. There are two types of metabolism that go on. And before I cover them, what do you guys think when I say metabolism? What are you thinking of? What's the first thing that comes to your mind when I say metabolism? Breaking down. Did everyone agree?
Yep.
Yeah, everyone pretty much agreed that metabolism is breaking stuff down. Well, that's half of the story. Metabolism has two components. It has what is known as catabolism. Okay. Catabolism, I'll write it over here. Catabolism is in fact breaking stuff down. Okay? And then there is anabolism. And anabolism is building stuff up. Okay, so you have two parts of metabolism. You can break things down and you can build things up. You can build new things. This is important because not every drug is necessarily broken down through metabolism. And we'll talk about some examples here in just a little bit. Okay? In general, metabolism is breaking down of a substance, or involves the breaking down of a substance. Okay? Of a medication. And when those medications are broken down or biotransformed, when a medication is changed by metabolism, we no longer call that a medication, we call that changed form a metabolite. So medications are biotransformed into metabolites. Okay? A metabolite. They may be broken down, or they may be turned into different substances. And I'm going to talk about this in a little more detail, not quite yet, but here in a little bit. We're going to talk about this in a little more detail because metabolism is so important. So, metabolism involves chemical reactions that change the medication. The medication is somehow changed. How is that accomplished? It's accomplished through what are known as enzymes. And you guys remember enzymes from pathophysiology, right? Enzymes are proteins, and they're proteins that make chemical reactions occur more efficiently. They reduce the activation energy needed to make a chemical reaction happen. Do enzymes make chemical reactions happen that wouldn't happen? They don't do that. They make chemical reactions more efficient, much more efficient. Okay? In the lab, we can add heat and we can mix things up, right? We can get things really hot and mix them up to make a chemical reaction happen more efficiently. But in the human body, we know too much heat tends to kill us, right? Tends to denature our proteins and all that. So instead we use enzymes, okay? Now, to make it more complicated, the activity of the enzymes themselves can be altered by certain drugs. Some drugs can induce enzyme activity. And induction means to make the enzyme activity more robust or more aggressive. So if I take a drug that induces a certain enzyme, that drug makes that enzyme work better, work more, okay? And then there's a situation where I can have inhibition. Some drugs inhibit enzymes. And that prevents enzymes from working as effectively. And to make it even more complicated, I could take one drug that inhibits an enzyme that helps me metabolize another drug. Or I could take one drug that makes an enzyme break a different drug down more efficiently. Do you see how complicated this can get when we start getting into what's known as polypharmacy, where you have people that are taking lots of medications? Those interactions can involve the induction or inhibition of the enzyme activity. Okay, so in general, what happens with metabolism is I take that drug and I turn it into polar metabolites. Generally, the general goal of metabolism is to make drugs more polar. Why do you suppose I want to have really polar drugs? So that what? Maybe distribution, but maybe I want a drug to go into the fatty compartment though.
Across the membranes.
Well, polar molecules don't cross membranes as well. Say it again. There you go. What is your major organ of elimination? The kidneys. So your kidneys are your major organ of elimination. So if I want to eliminate something, it has to go through the kidneys, right? And in order to get something through the kidneys, is it a good idea to have it highly lipophilic? No, because then it'll stay in the fatty compartment. It won't be in the blood, right? So if I can make that more polar, it'll dissolve in the blood, and then the blood can transport it through the kidneys, and I can pee it off. Does that make sense? So that's the goal. That's the general underlying goal of metabolism, is to take a drug and make it more water-soluble or more polar. So you make sure that it stays in the plasma and it has a chance at being circulated through the kidneys where you can pee it off. Does that kind of make sense there? That's the general goal. Unfortunately, the nature of metabolism is more complicated than that, and some complications happen. But that's the big picture of metabolism. Okay? All right. I'm not even going to hit these right now because I'm going to go into these a little more detail. So don't worry about all these different chemical reactions. We talked about catabolism and anabolism. Now, just to make it even more mind-blowingly complicated, some drugs have no pharmacological action whatsoever. And here's a mind-blower. Heroin is such a drug. Heroin has no action whatsoever. I inject heroin in you and it does nothing. Okay? It does nothing. Heroin is also known as diacetylmorphine. It is morphine that has two acetyl groups attached to it. But the acetyl groups make this morphine nonpolar. And so where does that morphine go? Not the liver. Nonpolar. Fats. Where in your body has a lot of fat? The brain, right? All that myelin in your brain. So I inject that heroin into you, that diacetylmorphine. It's nonpolar, so it gets out of your blood real quickly, right? And it goes from your blood into your fatty tissues, your brain. And then once it goes into your brain, there are enzymes in your brain that chop those acetyl groups off of the heroin and turn heroin, metabolize heroin into morphine. That is why heroin is so potent. But when you first inject it, it does nothing. It has no pharmacological action whatsoever until it passes into your brain and enzymes in your brain or in your body turn it into morphine. And now you have a whole bunch of morphine just sitting right there in your brain, and it's boom. Regular old morphine, if I just inject regular old morphine is not as nonpolar, so not as much of it gets into your central nervous system. But when I inject the heroin gets in there, and then it's turned into morphine, and so it has much more potent effects. Does that make sense? Drugs that when given, so if I give a drug and it's inert until it's biotransformed or metabolized into its active form, those particular drugs are what we call prodrugs. Okay, a prodrug is a drug that has no effects. Until after it is metabolized into its active form. And we call those active forms of drugs active metabolites. Okay, so morphine is an active metabolite of heroin or diacetylmorphine. Is everybody okay there? Okay? I don't know. I'm seeing some more or less. Okay. I know this stuff can be a little mind-blowing. It was really mind-blowing for me.
Do you know if there's any other drugs that do that?
Yes. And I'm going to actually give you guys some more examples. Yeah. There are lots of them. I don't know all of them, obviously, but yes, there are lots of drugs that are prodrugs. I'll talk about another very common drug that a lot of patients take. This is obviously taken for other medicinal, quote-unquote, reasons. But the other example I'm going to give you guys is actually very common, and it treats a certain disorder. You guys okay there? Yeah, you hanging in there?
What is it called after it's metabolized?
What's that?
What is it called after it's metabolized?
What is
prodrugs?
Prodrugs?
Active.
Active metabolites. Yeah, prodrugs are inactive, and they are metabolized into active metabolites. You're probably used to metabolism turning things into inactive metabolites, right? I think most of you intuitively understand, metabolism can inactivate drugs, which it can, but there just happens to be lots of cases where metabolism can also activate. And we call those active metabolites, and then of course we have inactive metabolites as well. Okie dokie, I'm not going to do that quite yet. All right, so metabolism rates vary quite a bit from person to person. Lots of different factors go into how your enzymes work. A lot of it comes down to genetics. And you guys remember we talked a little bit about genetics and pathophysiology, and you remember SNPs. Does anyone remember SNP?
Yes.
What does SNP stand for?
I just remember that I wrote SNP.
Just okay.
That's
SNP. It's single nucleotide polymorphism.
That's exactly.
There you go. So you have that code, the ACGT code, and one of those you pull one of those nucleotides out and you replace it, just one area, and you replace that, and you still have the gene, right? You still have the gene sequence, and that gene sequence still codes for the protein or an enzyme, but just one little area is a little different, right? And so the enzyme is going to be a little different. Does that make sense? And it's just one nucleotide that can make that difference. That's known as a polymorphism. So polymorphisms involving enzymes, very common. Okay, and some people can metabolize certain things very effectively, and some people can't. A coexisting problem like chronic liver disease, right? We have a lot of that actually in the U.S. Chronic liver failure, obviously. The liver is the major organ of metabolism, like the kidneys are the major organ of elimination or excretion. So anytime your liver takes a hit, your ability to metabolize, for better or for worse, is going to be altered. And then even drug interactions. Okay, we're going to move away from metabolism, but we will swing back around in just a little bit and talk about it in a little more detail. I want to talk about elimination now. So, liver, primary organ of metabolism, and it's the enzymes that actually help, that make metabolism possible. Is everybody okay there? Everybody tracking okay? Cool. All right, so we get rid of most of our stuff through the kidneys, okay? Now, there are other ways we can eliminate stuff, okay? I can eliminate stuff through my breath, through the lungs. Ethanol or alcohol can be eliminated through the lungs, a small portion of it. We can eliminate stuff through sweat, and we can eliminate stuff through our fecal matter as well. Those are all minor pathways for elimination. And in fact, when it comes to stuff that's really hard to make polar, like fats and lipids and things like that, a lot of that stuff has to be eliminated through your GI tract. A lot of your fatty stuff, if you can't metabolize it into more polar forms. So that's how you get rid of lots of your fat. A lot of your fats is through your bile. It gets dumped into your bile, and then it gets pooped out. Okay, so elimination. Well, you need to have good glomerular filtration, okay? So you need to have good perfusion going in and out of the glomerulus, okay, in and out of those Bowman's capsules in your kidneys. Okay, your tubes, your tubules need to be working. You need to have good secretion, and if they're reabsorbing a lot of that drug, that means that it's not being eliminated as efficiently. So bottom line, if you have impaired renal function, you're going to have impaired elimination. Okay? Just like if you have impaired hepatic function or liver function, you're going to have impaired biotransformation or metabolism. Like I said, some things can be eliminated other ways, like volatile gases, like anesthetics, for example. Most of your volatile anesthesia agents are going to be eliminated just through the pulmonary system. Ethanol is another one. All of your alcohols, to some extent, can be eliminated. All right. Woo. So now we've gotten through pharmacokinetics. Pharmacokinetics is what the body does to the drug, and it starts at how the drug gets absorbed, how it's distributed, how it's metabolized, and how it's eliminated. Is everybody cool with that? More or less? The bigger picture? So now what we want to do is we want to talk about what the drug does to the body a little bit, okay? What the drug does to the body. And that's known as pharmacodynamics. The big picture of pharmacodynamics is that most of the drugs that we give, most of the medications that we give, act through receptors. Okay, virtually all the medications that we administer act by either antagonizing, that is, what's antagonizing? If I antagonize something, antagonize in biology doesn't mean to piss it off so much as to prevent it from working, right? Plug it up, stop it from working. Like Narcan is an opioid antagonist, right? It blocks those opioid receptors. So whatever that opioid agent is can't attach. So some drugs antagonize receptors and other drugs agonize. And what does agonize mean? Activate. Agonize is activate, and antagonize is to deactivate. Is everybody cool with that? All right. So we talked about what receptors are a little bit in pathophysiology. They're large macromolecules, generally proteins. Okay, they can be either protein channels in cell membranes, or they can be what we call ligand-gated ion channels, which is a protein channel, or they can involve something known as a secondary messenger, and we'll talk about that in a little more detail a little later on, but I want to kind of keep it basic right now. Okay, so you can have selectivity. And when we talk about the selectivity of a drug, that is the extent to which it acts on a specific receptor. So I could give a drug that could attach to a certain receptor, but it may not be very selective. For example, epinephrine. What do we know about epinephrine? Is epinephrine very selective as a drug?
No.
It's non-selective. It's really good at activating alpha 1, beta 1, and beta 2 receptors. It's not selective particularly to those 3 receptors, is it? It activates all 3 of them very rigorously. However, there are other drugs such as norepinephrine, okay, which is a modified epinephrine molecule. Norepinephrine is much more selective to the alpha 1 receptors. Does that make sense? So epinephrine is not as selective. Okay, it attaches to multiple receptors, but norepinephrine is much more selective to alpha 1 receptors. Another drug that we'll be talking about later on in the course, dobutamine. Dobutamine is highly selective to beta 1 receptors. Albuterol is highly selective to beta 2 receptors. So some of the drugs we give are highly selective, and some of the drugs we give are not as selective. Is everybody okay there? All right. Obviously, few drugs are absolutely specific for one receptor. Okay. All right. So the general thing, and probably most of you learned this when you took your pharmacology as intermediates or advanced EMTs. You remembered something known as the lock and key model. You guys remember that? The lock and key model? And probably what you were told was that a drug is like a key, right? And the receptor is like a lock. And the drug could go into the lock, and it could do one of 2 things. It could unlock, right? Unlock the receptor and open the door up, or it could lock the receptor and prevent it from working. Is everybody okay with that model, the lock and key analogy? It's actually a pretty good analogy. Not perfect. It's not really what's going on, but it's a pretty good analogy. So what happens is drugs are what we call ligands. And you guys remember reading about ligands in pathophysiology, what a ligand is? A ligand is just something that can attach to a receptor. So drugs act as ligands. They attach to the receptor, and they induce what's known as a conformational change. Remember, we talked about conformation in pathophysiology, how proteins have a very special shape. And what drugs do is they can change, even ever so slightly, the shape of that receptor, and that causes that protein to do something. Okay, it causes something to happen. Okay, it can be lots of different things. It can cause an ion channel to open up or to close. Okay, for example, you guys have heard amiodarone. Maybe some of you have been on codes where the paramedic administered amiodarone. Has anyone ever heard of that? Amiodarone? Yes. Yeah. Amiodarone, among other things, can block potassium channels. It can prevent potassium channels from opening up. You guys are familiar with something called lidocaine, right? Lidocaine, you probably have used, maybe if you've done IOs, you may have even used it to flush the IO. And it may be given for certain cardiac dysrhythmias. Lidocaine prevents sodium channels from opening up. It locks the sodium channels. Okay, is everybody okay there? Those are just a couple of examples. Okay, so you can open or close an ion channel, or you can activate biochemical messengers. Okay, and this is called secondary signaling. So, what I want to do is I want to give you an example of these 2 processes. So I'm going to turn the lights on and we'll look away from the PowerPoint for a minute. And I'm going to give you an example of how this works in two different ways. Okay, the first thing that I'm going to do is I'm going to talk about the neuron. We'll talk about the neuron, the nerve cell. Everybody's okay with that. So I have neurons, or these nerve cells. So here's my neuron. Everybody's cool with that? Now these nerve cells are a lot like cardiac cells. They are able to depolarize, and that's part of how they communicate, right? Is they can depolarize and send signals away from them to other neurons. Everybody's okay with that? So neurons, just like cardiac cells, contain lots of potassium inside, and where's all the sodium?
Outside.
Sodium is outside. And there's much, much, much more sodium, obviously, than there is potassium, right? Would you guys agree with me?
Yes, because I got that wrong on the test. So.
Okay. Okay, there's a lot more sodium, right? 135, 145 milliequivalents per liter versus potassium. So, would you guys agree that if you were to compare the outside of the cell to the inside of the cell, that the inside is going to be negative compared to the outside, right? Because there's so much more positive out there. So we say the potential across this membrane is negative. Everybody's cool with that? So for a neuron to depolarize, the neuron's potential, let's say that this is 0 here, and this is negative 70 millivolts. Okay? The resting potential for the neuron is down here, right? And then what happens to get that neuron to depolarize, okay, enough sodium has to enter the cell, okay, to bring it up to what's called its threshold, and then it depolarizes and then repolarizes. Is everybody okay with that? More or less makes sense?
Yeah.
Okay. So what I'm going to do now is I am going to give my patient a medication that acts on a specific channel. Okay? It acts on a specific channel or a specific receptor. All right? And this receptor is called a GABA receptor, gamma aminobutyric acid. I have to memorize that quite yet. Gamma aminobutyric acid, GABA receptor. That's a neurotransmitter in the central nervous system. And the medication that I'm going to administer is a benzodiazepine. What are benzodiazepines?
Activates the GABA.
Okay. So benzodiazepines include things like Valium or diazepam. Okay. They include things like lorazepam or Ativan or midazolam, which is also known as Versed. Okay? So these are sedatives, right? These are sedatives. And what these do is, these particular medications bind to the GABA receptor, and they make the GABA receptor more responsive to the GABA neurotransmitter. And ultimately what the result is it causes this channel to open up. And this channel, when it opens up, it allows chloride ions to rush into the neuron. So what do you suppose happens to the membrane potential if I give my patient an injection of lorazepam and their GABA receptors open up and all that chloride rushes in? What's going to happen to the resting potential of that neuron?
It goes up.
It goes up or it goes
Now.
because I have a bunch of negatively charged stuff entering, and the potential is already negative, right? So what's going to happen?
Oh.
It's going to push it down, and by doing that, is the neuron, are you going to have to stimulate the neuron more or less to get it to actually fire?
More.
More. You have depressed that neuron. That is how those particular, the benzodiazepines work. And so we call these ligand-gated ion channels. Okay? That is one of the two major ways that drugs work. They work on ion channels, like benzodiazepines, or through another mechanism known as a secondary signaling. And I'll just give you guys an example of secondary signaling, really big example of a medication you guys have all probably administered. So, I'm going to give you an example of a beta receptor. Okay? I have a beta receptor on the surface of some smooth muscle that's wrapping around the bronchial of an asthmatic patient. Is everybody okay with that? And I'm going to give a drug like albuterol. And that albuterol is the right shape to fit into that beta-2 receptor. Everybody's cool with that? So albuterol fits in there, and it agonizes the receptor. It turns it on. You guys cool with that? Turn that receptor on. And what happens is, instead of opening or closing a channel, like up here, something a bit more complicated happens. That receptor in the cell membrane, on the inner part of the cell membrane, that receptor is attached to a little 3-unit protein called a G protein. And when that receptor gets activated by albuterol or epinephrine or anything else that can activate beta-2 receptors, it causes these proteins, these 3 proteins to dissociate. There's actually an alpha, beta, and a gamma subunit that dissociate. And ultimately, they cause another protein inside of the cell called adenyl cyclase. They activate this protein, and this protein gets turned on, and what it does is it converts. It causes ATP. You guys all know ATP, right? Adenosine triphosphate. Adenyl cyclase converts adenosine triphosphate into a molecule called cyclic 3' 5' adenosine monophosphate, or we simply just call it CAMP, C-A-M-P. And it is the CAMP, when the CAMP level inside of the cell increases, ultimately that is what causes the muscle to relax and causes the bronchodilation to occur. So in this instance, what's happening is the albuterol is activating a receptor, and the receptor is causing a secondary messenger inside of the cell to do the work. Does that make sense? There is a secondary substance that is created that actually has action. So this is known as a secondary messenger system. So you have drugs that work by ligand-gated ion channels and drugs that work through secondary cell signaling. And this particular process here is known as a G protein coupled receptor, okay, or G protein coupled response. And a good number of the drugs that we administer work through G protein coupled receptors. Albuterol just happens to be a really major example of one. There are many others as well. Okay. Now, I'm not going to ask you to regurgitate all that, okay? So don't worry too much about the details. I actually remember being in respiratory school, and I had to regurgitate that and much more. There's a lot more steps there, but I actually had to regurgitate all of those steps. I hated it so much. It was not fun. I won't make you guys do that, though. Okay, so we said there's the lock and key theory. And the lock and key theory generally works pretty good. Okay, it changes the conformation of the protein. Let's see, it's 2 o'clock. Get out of here for 10 minutes. Let's get you guys on a break.